السلام عليكم يا شباب. أنا عزمي عبد الرحمن عمارة, Specialty Registrar in Endocrinology and Diabetes in Newcastle. I have been asked to talk to you tonight about two important concepts in quality improvement in healthcare, which are clinical audit and quality improvement projects. We decided to divide this talk into two sessions. Session 1, during which we are going to address the basics. So it's going to be mostly about introduction to these concepts, and we'll give you an account of our experience when we first came to the UK, in addition to experience from other colleagues from different parts of the world who started their NHS career in the last few years. I'm a lazy person, so when the guys asked me to do this talk, I did what lazy people do. I asked other people to do my work for me. So you will be hearing from my friends and colleagues, Owen, Ayat, Neve, Tom, Khalid, Angelis, and Sue and Tees. And many thanks for Hosam Hamad to edit most of the videos for us. So why do we think these are important topics and we need to tell you about? Because there is little teaching in Sudanese medical schools, and in fact when I spoke to my colleagues who didn't study in the UK, they didn't have any prior experience in their medical schools, wherever they're coming from, Malaysia or Canada or Spain or Poland. As a result, there will be a huge gap in our knowledge, in our experience when we come to a country like United Kingdom or Ireland, where they are heavily investing in such projects like audits and quality improvement projects. So it's a paramount type of knowledge that we need to have, because it's a crucial part of our practice in the UK. It is an opportunity to improve our healthcare, our work conditions, and our clinical practice as well. It's also important to mention that you are required as a trainee or as someone who undergoes a regular revalidation process to have some sort of involvement in one of these processes. So what this session is about is going to be a very basic introduction. It's just an appetizer. You are not going to walk out with full-blown knowledge or expertise in doing audit or quality improvement projects. And I would imagine the target audience who would probably benefit the most from this talk will be people with little knowledge or experience in clinical audits. So I would imagine my colleagues who are still in Sudan but they're preparing to come over to the UK, or our junior doctors who just arrived in the UK and they are in their first year in their NHS experience. I expect this session to generate thoughts and questions rather than answer all the questions, but indeed we will try to provide few answers for the main concepts. So we will go through the definitions of audit, research, and quality improvement project. I'm going to touch briefly on the difference between clinical audit and research. My colleague Owen Leng is going to chat to you about why do you need to get involved in these processes. I will explain briefly the audit cycle, and we are going to give you an example of a project that we have addressed once using a quality improvement project process, and a second time using the audit, and that should hopefully help you to appreciate the difference between the two processes. As I said, you will hear many reflections from colleagues who graduated from Canada, from Spain, Malaysia, or Poland about their first audit experience, and Khalid Yahya is going to tell you about his experience with his new audit when he arrived in the UK. In the end, you are going to hear from one of my colleagues, one of the clinical pharmacists, when she was involved with us in doing a multidisciplinary sort of based approach to our quality improvement projects. Now, I want you to be familiar with these two concepts, just for the sake of familiarity for now, because we are going to talk about them in a bit in depth in session 2. So quality improvement in healthcare is simple. It's like any other concept of quality improvement. You want to go from point A to point B. You are assuming that point B is going to be better. The process that you are going to pursue to get from point A to point B this is the process that you are going to get there, and that might be a QIP or it might be an audit. Another terminology that you are going to hear a lot of time, week in, week out, we are going for a clinical governance meeting, Clinical governance, in simple terms, is the process by which you improve standards. Then you are going to set standards for people to follow. But as I said, at this point in time, all what I need from you guys is familiarity with these terms rather than knowing them in and out. Now, you can ask a question, why do I care about this? I know medicine, or I know surgery, or I know my ops and gynae. And in fact, yeah, they are really boring topics to talk about, but they are essential. They are very important for you to proceed with your career in the NHS and in Ireland as well. But the simple analogy for that would be, if you see a patient in clinic who smokes or who drinks alcohol excessively, you are going to ask them to quit smoking, have a walk for 30 minutes, lose weight. So you are actually trying to improve their quality of life or their health by asking them to change their attitude. And I think we shouldn't hold ourselves to a lesser standard, to the standard that we are expecting our patients to be at. So it's difficult for us to change our attitude to focus on stuff that we are not familiar with, like audit or healthcare or clinical governance, etc. But it's not as difficult as it seems. Now, what you'll find helpful when you work in the NHS is the team sort of spirit. If you take this group for example, the quality example here, we assume that point B, which is the black diamond on the floor, is far better than that cup which is full of coffee to be 2 meters from the ground. And what we will ask our team to achieve that sort of leap from point A to point B is to take that cup which is full of coffee from point A to point B, which is the black diamond, without splitting any amount of the coffee. And that seems to be a simple task, but when there are many elements, when there are many people and organizations involved, that is really, really difficult, because you need all these people to move the same pace, synchronized, to get that cup from point A to point B. And sometimes we succeed, sometimes we fail, sometimes we miss by a margin. And this is where we need to identify where are the weaknesses and how can we address them as a team. They didn't miss by far. Now, definitions, if you go online and you try to look for definitions for audit or quality improvement projects, there are many definitions. These are 2 different definitions, but I felt they complement each other. So the first definition defines audit as a systematic and critical analysis of the quality of clinical care, which includes the processes, procedures used for diagnosis, treatment, the associated use of resources, and the effect of care on the outcome and quality of life for the patient, which is fine. But if you remember from my short talk in the last few minutes, what I said about quality improvement is that you need to make a change. You need to move from point A to point B. And this definition doesn't seem to address that very well. A second definition, if you combine the second definition with that, it works fine, at least for me. The attempt to improve quality of medical care by measuring the performance in relation to a desired standard and by improving on this performance. So we should always have a standard which we consider that's our top standard, that's our perfection point, and this is what we will be aiming for. And then you measure what you do in your organization, in your ward, in your unit, in your clinic. How far are we from that standard? Measure the difference. If there is a significant difference, if there is a problem, then you are going to devise a method by which you are going to try and address that gap to improve your performance. And that's simply what audit is about. Identify a problem, identify a standard, measure how big the gap is, identify or devise a method to get from that point to as near as you can to the standard. So I would say audit is a systematic and clinical analysis of the quality of clinical care. It's an attempt to improve quality of medical care by measuring the performance in relation to the desired standard and by improving this performance. Now, there are a million causes why we do it, and it's obviously everyone wants to get better, and I'm not going to dwell much on this slide, but it's improvement, it's an opportunity to improve care, it's an opportunity to improve our practice, etc. Now, as clinicians, why do we need to get involved? You can make that argument of, I want to come to my clinic, I want to see my patients, investigate, treat, and that's it. But there are many good reasons for you to get involved with these, which my colleague Owen Ling is going to tell you about in the next few minutes.
My name is Owen Ling. I'm a specialty trainee in diabetes and endocrinology based in Newcastle in the United Kingdom. I've been asked to speak to you today about why you should consider getting involved in the world of audits and quality improvement projects. There are a variety of benefits that these processes offer you, but I've broken these down into three broad categories for us to consider today. Firstly, we're going to have a think about what benefits these processes offer to our patients. In the United Kingdom, the processes of audit and quality improvement projects are considered essential ways of maintaining standards. The process of comparing your unit's results to standards set at either a regional, national or international level are considered an essential way of showing and maintaining standards. They can also be a way of driving up standards and improving the quality of care we offer patients. Therefore, for anyone who's hoping to make an impact on patient care beyond their practice at a local or regional level, this is really a fantastic opportunity. Secondly, the processes offer benefits to you personally. They are an opportunity to develop a specialised knowledge regarding a specific area of patient care. They are an opportunity to develop transferable skills, be that in the process of developing ethical approval, data acquisition, data analysis, statistics, or in the presentation or publication of findings. The process of audit or quality improvement also provides opportunities to present your findings, be that at a local meeting, a regional meeting, a national conference, or potentially an international conference. For those projects which are of interest beyond your locality, there may also be possibilities to consider publication of your findings. And this brings us on to the third broad area of benefit, and that is of the benefit these projects offer to your future career. They are a fantastic opportunity to show ongoing commitment to a specialty. They provide excellent opportunities to network with clinical leaders within that specialty, both through the process of audit, but also when it comes to presenting your findings. Audit and quality improvement projects also really do stand out on your CV, particularly if you manage to take them to presentation at a national meeting, or if you manage to publish your findings. And therefore, they are a fantastic way of making sure that you stand out as a candidate when it comes to job applications. And this can be of particular importance if you're considering application to a really competitive specialty or to a competitive locality.
Right. Now we know what quality improvement in healthcare is. We know the definition of audit. Now, how can we do it? And that's simple by understanding this simple cycle, which we call the audit cycle. An audit process starts by identifying a problem. Let's say, for the sake of argument, that you notice that in your ward, hand washing is a problem. And as a consequence of that, let's say that the infection control department in your hospital think that the rate of hospital-acquired infections in your department are higher than the other departments, for example. So let's say that is the problem. Then what your next step will be to go and try and find, is there any standard that we will be looking at to try and address this problem? And let's say, for the sake of argument, there is a national guidelines about hand washing. Let's say every healthcare professional should wash their hands before and after seeing patients for 2 minutes. Okay, so that's the standard. Then you would decide whether you would like 100% of that standard to be applied, or would you like to be more realistic and say, well, I would like about 70% of my staff to wash their hand before and after. So you've set that as a standard. Then you are going to design a method to collect the data, as in to know how many people are washing their hands before, after, etc. Your next step will be, you are going to collect the data, and then you are going to look into your data to see whether the standard has been met or not. If the standard has been met, that's fine. If the standard hasn't been met, then you are going to ask the question as in why. And when you find that answer to why, you are going to come up with a plan to implement that change. Once you come up with a plan, then you watch people doing it for a few weeks or a few months, and then you are going to re-audit again. And that's very important. An audit from one cycle is useless. You have to complete the loop by re-auditing your process. And I'm going to go onto that process in more detail in the next few slides. Right, so that's someone who had actually done this project before. In 2010, there was a study in the US identified that there are a lot of deaths secondary to hospital-acquired infection because allegedly the staff don't wash their hands according to standard. Okay. Then that person had set a standard that 70%, for example, of healthcare professionals should wash their hand before and after. Okay, and he wanted to be smart in his objective, so he put a time frame for that, for his objective to be time bound, and he said, I would like to improve the hand washing in 70% of the staff by the 1st of December, which is about 10 days from now, I think. Okay, then the next process is to collect the data and analyze them. Okay, and now this can be tricky because you can ask the question of, how am I going to measure that change? Am I going to ask someone to stand in each bay or on the ward to watch whether doctors are washing their hands before and after? Someone else might say, no, let's just measure how many soap dispensers we are using in the next 2 weeks compared to the last 2 weeks. And that can be an indirect method of measuring how much soap we are using as an indirect measure to hand washing. It might not be accurate, but you can make an argument that if a ward has been using, let's say, 2 soap dispensers, and then in 2 weeks' time after you made your change, you find that the same ward now is using 15 soap dispensers, you would assume that they are washing their hands more often. Okay, then you analyze your data, and let's say this is your data. So we've put 2 criteria. Criteria number 1, hand washing before seeing a patient. Criteria number 2 is hand washing after seeing patients. What standard did we decide on? 70%. What we actually found is that 45% of healthcare professionals wash their hand before seeing patients, which is not meeting the standard. and 55% of healthcare professionals, I apologize, are not washing their hands after seeing the patient. So clearly, we are not meeting the standards. Then the next question will be, why not? And then someone might say, well, we don't have enough, say, soap dispensers, or I don't have time. There are many people that I need to see. If I wash my hands for 2 minutes before, 2 minutes after, and I've got 60 patients, I'm going to spend 3 hours washing my hands in a day. So you try and address that issue. If it's a soap dispenser problem, you address that. If it's too many patients for a doctor, try and increase the number of doctors seeing these patients. And then you come up with recommendations to fix the problem. Now, you fix the problem, you are implementing a change. And what you need to do, because this is audit cycle 1 is finished now, what you need to prove is what you have done in terms of policy change is actually working. So you go through the same process again, same standard, 70% before, 70% after. You give them 2-3 weeks, you collect your data, and then you analyze it. Are we meeting the standard or not? Well, we are improving, but we are not meeting the standard. Right. Why? Let's fix this, let's fix that, and let's do a third audit cycle. And this is how it works. Okay. So this is a very brief introduction about audit, and I'm going to give you a very quick note on quality improvement projects. They are essentially very, very similar. The major difference is audit has such a stronger standard that you would lean into when you are comparing your performance to that standard. A quality improvement project, you can just rely on any good clinical practice, any good example, rather than a strict sort of standard. Okay. So again, similar definition. It's an application of a systematic approach that uses a specific technique to improve quality, which could include the concept of cycle improvement, but that's not necessary. You don't have to repeat a quality improvement project because it's a continuous process. Okay. Likewise, there is what we call a PDSA cycle in the quality improvement projects, and P stand for plan, D stand for do, and S study, and A for act. So you have to improve on, say, patients. Since admission, patients should be seen, say, within 4 hours. This is our plan. Let's do it. Let's collect the data in 2 weeks to see how many patients are actually seen within 4 hours. We find the data. Well, only 60% of patients were seen within 4 hours. Why? Well, because we have only 2 junior doctors in the acute assessment unit and they can't manage all that. Okay, let's put 2 extra doctors and let's assess whether that is going to change, and that's your act. Okay, so essentially both processes are very, very similar. The only strong difference between the two of them is that with audit you have much stronger adherence to standard. There are formal standards to compare to when you compare that to a quality improvement project. Now we come to talk briefly about the difference between audit and research. As I said, audit already compares performance or a practice to a named standard. So there is a standard, there is a defined good clinical practice that we are trying to compare what we do to that standard. Research always generates new information. That's why research defines good practice. Simple example, 70 or 80 years ago, you are trying to establish whether penicillin is actually a treatment for pneumonia. What you need to do, you get patients with pneumonia, you try penicillin, and if you've got a statistically or clinically significant result, you can say, yes, we conclude that penicillin treats pneumonia, and this is our good clinical practice now. We have established that. Now we've got a unit who treats patients with antibiotics, and we want to see whether this unit is actually adhering to that practice of treating pneumonia with amoxicillin or coamoxiclav or any other penicillin derivative. Okay. research might involve allocating patients to random treatment groups, and this is what we do in a randomized control trial. In a clinical audit, you never do that. In a research, you might involve a placebo treatment to come up with more robust results. In an audit, you will never use a placebo treatment. Audit, again, it doesn't involve any new treatments because you are always comparing what you do to something that has been established, and usually all of these new treatments are established in randomized controlled trials and researches. An audit is an ongoing process which can be repeated on and on and on and on. Research can be repeated, but usually it's a one-off process. Okay, so when do we use the research? When we don't have a good practice and we wanted to define a new practice, and a comparison is usually needed. In audit, good practice, as I said, is already defined, but we want to know how much are we adhering to that good practice. Why we do research? To define good practice. Why do we do an audit? To improve our current performance. Now, to give you something that will hopefully make you make sense of what I've been saying in the last few minutes, my colleague Ayat is going to give you an example. We have identified a problem about confidence of junior doctors managing diabetes in patients who are receiving steroids. And Ayat and the team tried to address that problem. They used a quality improvement project to start with, and then they used an audit to look at the same problem. So have a look at her example.
Assalamu alaikum wa rahmatullahi wa barakatuhu. My name is Ayat Bashir, and I'm currently a clinical research fellow in diabetes. I recently completed the foundation program in Newcastle and hoping to pursue a career in academic diabetes and endocrinology. My segment today is an example of a quality improvement project and audit, and how initially basically you can do both around about at the same time. I hope you enjoy it, and if you have any questions, just please let me know. Thank you very much. Assalamu alaikum. Okay, so moving on to providing an example of a quality improvement project and audit. I've labelled this as two sides of the same coin, because essentially the quality improvement project did lead to the audit and was utilised as part of the audit. And those are the titles provided. Lack of confidence in management errors in diabetes, a 3-minute solution, was the quality improvement project, and the prospective review of incidence of blood glucose monitoring in medical and surgical patients receiving steroid therapy was the audit. So where do you start? So we've already, as part of this talk today, we've already gone through the process of quality improvement project and audit. However, just as a reminder, this is the format that we're going to be using today for the presentation. We're going to be talking about identifying areas of change, setting aims, designing an intervention, testing changes, and implementing changes, and all through example of a project that I completed. So how do we identify an area for change? Well, simply you can look at areas where there's been a high incidence of reporting of errors, or patient complaints, or even a previous audit which has identified areas for further improvement. So for example, what I did is I looked at, there was a previous audit, a national audit which was conducted in our trust, identified that there was a problem with management errors in diabetes. So I thought to address this by initially taking a look at where the problem lies, or where the problem may lie. Like we said, the National Diabetes Inpatient Audit demonstrated that 30% of patients with diabetes experienced at least one management error in the Newcastle Trust, and that became my focus for my quality improvement project. So the next step would be to set aims. And a good quote is, if you don't know where you're going, you're probably going to end up somewhere else. So it's really important to set aims to allow you to develop your project. And my aims were, number one, to determine the level of confidence of junior doctors, because it could be that the junior doctors didn't have much confidence in the trust managing patients with diabetes. And what I wanted to do then is to develop a podcast to address any human factors or a medical error, and to conduct and evaluate a session. So this was essentially part of a medical education project, which kind of developed into a quality improvement project. So how did I go about doing this? I developed a questionnaire, piloted the podcast, and did a pre and post teaching assessment to assess impact. So the main question I had from kind of the audit is lack of confidence a problem? So what I did was simply go out to the normal F1 teaching that they have on a weekly basis and designed a questionnaire based on a pre-validated questionnaire, which I found by doing a literature search, and gave the questionnaire out to the foundation doctors and got a good response. About 27 junior doctors filled out the questionnaire, and the questionnaire identified problems that junior doctors might have experienced. So based on that, I designed an intervention, and intervention was a podcast because I did realise that junior doctors are very busy, and we can't just be delivering 1 hour teaching sessions to improve quality of care. I decided to do a podcast which was 3 minutes, which can be easily played in people's own time or on the ward in the middle of lunchtime. So it was a 3-minute audio-visual podcast, which was based on a good scenario and a bad scenario, and with common mistakes and top tips. It looks a bit like this. So these are examples from the podcast video. So Team Red was the bad, and Team Green was the good. And it's just a simple way of showing people how not to do something and how to do something. So I've got the questionnaire, which identified that probably managing patients on steroids is a problem amongst junior doctors. I designed the podcast to address this problem, and the next step would be to test the changes. And the way to do that is I went in a lunchtime and targeted a few of the medics on the ward and asked them, would you be able to watch this video, and we'll talk through it. And before that, what we would do is do just a general assessment of their knowledge, their baseline knowledge, piloted the video, and then we did an assessment afterwards. And we also did a feedback and evaluation to see how this can be improved, and how this can also possibly be implemented. So this is just an example of results from the questionnaire. Altering diabetes therapy in patients on steroids. People were more towards the not so confident end of the scale. And this is the results of the pilot session. So we had the trainees and medical student, the assessment pre the podcast, and the assessment post podcast. And generally there was an improvement in their knowledge and their confidence, and the evaluation deemed was relevant to their workplace. So moving on to implementing the changes. So we've designed a podcast, we've tested it. It does seem like a good initiative. How are we going to disseminate this and implement changes on a wider scale? So what we decided to do is to conduct the study on a larger scale. Obviously we need to kind of test it out on more people than just the 5 people that we tested in the group, to set up a focus group to identify further barriers, and most importantly to see how this is affecting our current practice. And the way to do that is to audit. So we flipped the coin over to audit. This was quite simple because I already established what the problem was. So I identified my audit topic, which would be steroid therapy in diabetes, and utilising very similar aims to the quality improvement project was to look at the blood glucose monitoring, to assess the incidence and management of steroid-induced diabetes, and to assess the impact of the 3-minute podcast, which I'd already designed from the quality improvement project. So the second part would be to set the standards, and the most important thing is to set standards which are quantifiable, to have several standards which are developed from trust guidelines, national guidelines, and if there aren't any guidelines, it's best to go with expert opinion, discussing with seniors, and to see to set a few standards. And the most important thing is to have percentages to see, so that you can, when you're doing your data analysis, you've got something to compare it to. So those are my example standards. I designed a spreadsheet so we can collect the data, identify people that will help with data collection. It can be, depending on what you're doing, a difficult task just to collect data yourself. So once you have the spreadsheet, share it around to colleagues who are going to be willing to help you out with the presentation, with the data collection. And the next thing would be to analyze your data. So once you've got your numbers, once you've got your spreadsheet filled out, The most important thing would be now to then compare it to your initial standards. So, for example, standard 1, we're aiming for 90% patients appropriately screened for hyperglycemia. And if you look at our percentage, it was only 20% in our initial audit. And likewise, for standard 2, it was 20% recorded within 24 hours of commencing steroids, where we would hope 100% of patients would have their blood glucose measured within 24 hours. So this is just an example of having your data and comparing it to the standard. So when we go out to implement change, we think about completing the cycle. So with the implementation of change, we look at what we can do to improve our current audit findings, and then what we need to do is re-audit. So what I used is the podcast that I designed from my previous quality improvement project, and with the feedback that I got in the evaluation session, we generated the recommendations from the initial audit. So the initial recommendations was to incorporate a podcast, to upload the podcast on Trust Internet, to develop a system online so that people can get reminders to check their blood glucose, and to re-audit it, the topic. So again, you've seen this slide before. It's my podcast that I designed, and what I did is use that to improve on the medical and surgical wards their knowledge of steroids and blood glucose monitoring, so that we can re-audit and see if we've made an improvement. So we piloted this again to the neurosurgical wards, and a larger number of staff members attended. We made them watch the podcast. If they had any questions, we answered them. And then we did another further audit, further 2 weeks of monitoring. And this is just an example of comparing your previous results from the initial audit, which is in blue, and then the re-audit, which is in green. And generally, we saw an improvement from the first audit, which is in May, to the second audit, which was in July. So to summarize, we had an initial audit, we tested out our change, we implemented the change by delivering a teaching session with a pilot, and then we did a re-audit to see if there's any improvement. And after that, the most important thing would be then to disseminate your audit findings, to present your results so that other people can benefit. So I presented it locally in the trust, and more regionally and nationally in elsewhere. And this was kind of the final project. So we did a poster project, again with the layout, having your background information of how you identified change, you had your aims, and the methods which we used, and the standards, the intervention, which was a podcast, and displaying the results, and developing conclusions. And there's always further recommendations. So even if you do a re-audit cycle, you're never going to get perfect results. There's always going to be something new that you had identified that could be changed. And this could be a trigger for someone else down the line to re-audit. So someone might have already done something like this, and you can then pick up on their recommendations and develop a new intervention and do another re-audit. So to summarize, an audit quality improvement project does not need to be a difficult task. Pick a clear area for improvement. It can just be something that you see on the wards and that you can really just improve on the wards by educating, for example, and incorporate your quality improvement project to your audit, and that's where you would have scored both points in both areas. Thank you very much, and happy to take questions.
Right.
Moving
on. Again, an important part is that you should recognize the role of different teams in the ward. So it's not necessarily that you do an audit by yourself. There are audits which you can involve physiotherapists, occupational therapists, nursing staff, diabetes nurses, or clinical pharmacists. I had an opportunity to do a quality improvement project last year about how to rationalize medications in elderly patients, mainly patients who are older than 70 years old. And I had an opportunity of working with our clinical pharmacist on the ward, and I will let her tell you her experience from doing shared sort of multidisciplinary audit with us as medics.
Hello, my name is Niamh O'Connell and I'm a clinical pharmacist. I've been asked today to speak to you about my involvement with audit and quality improvement projects. In the past, I have carried out audits as an individual, and these have been really good at reviewing our current working practice in line with both local and clinical standards. Last year, I had the opportunity to be involved in a multidisciplinary team quality improvement project. This was led by one of the registrars on our ward, and he involved the pharmacy team from quite an early stage in the project. It was quite good because it looked at the use of a medicines optimization tool on a busy endocrine ward. The data that we got from this quality improvement project was quite promising, and it has since been presented at both a local and a regional level. I would highly recommend that if you are going to carry out an audit or a quality improvement project, that you try utilise the multidisciplinary team that you have available to you. Speak to the nurses that may have a particular interest, or speak to the pharmacists that you work with, and see if there's any areas that they may be able to help you with. By involving a different member of the multidisciplinary team, you will help identify any areas that may be a slight weakness in your audit or your quality improvement project, and it will also be an extra pair of hands for things like data collection or data analysis. Previously, I have worked with medics on my ward carrying out basic audits with regards to the safe prescribing of insulin. These have been really beneficial because not only do these audits benefit the medics, but they also benefit the wider multidisciplinary team. They are keen interests for pharmacy because it involves the safe prescribing of a medicine, and they're also really beneficial for the nurses because they are the people who administer it on a daily basis. So that's one simple audit that affected 3 members of the multidisciplinary team. Finally, all I can do is try and encourage you to work with the different members of the multidisciplinary team that you have. Not only will it help strengthen your audit, as I've mentioned in the past, but it will also help build really good working relationships within the multidisciplinary team. Thank you.
Okay.
Good afternoon or morning, everyone. My name is Sue T. I'm one of the Diabetes and Endocrinology registrars here in the Northeast. I qualified from Newcastle University in 2009, and as part of our medical school training, we were introduced to the idea of clinical audits in 4th year, where we had to do an audit project and were assessed on it, including how to produce a poster from the results. So today I've been asked to speak to you about top tips in carrying out a successful clinical audit. I'm sure you've had lots of teaching on this already, so I'll try and keep it brief. I've got 5 points, and here goes. So my first top tip is to select a good topic. A good topic to me is something that is easily improved, is a known quality issue, and is achievable in the short term. And one useful thing I found helpful in the past is to go to your supervisor or consultant and ask them what's been done recently in the department so that you don't repeat someone else's work which has been done fairly recently. Another useful idea is to ask them what needs to be re-audited. They are often national or sort of trust-wide audits which need to be regularly done, so you can start off from there. My second point is to set SMART standards. SMART stands for specific, measurable, agreed, relevant, and theoretically based. There are lots of useful websites about how to set SMART standards, and I think that's a very helpful framework to set your audit standards by. Places to look for guidelines are, for example, the NICE guidance, which is national. Societies it often has useful guidance on various topics, and less helpful but equally important sometimes are to go to your local hospital guidelines to see what needs to be audited locally. My third point is to actually keep it simple. A simple project is more likely to get done in a realistic frame of time, and it's easy to measure change if you've got very simple to measure data. For example, the percentage of people getting foot examinations, just a simple one. Simple topics are also easier to replicate and re-audit in the future, and you're more likely to get a re-audit done successfully if you pick a simple topic. My fourth point is to actually shout for help. Lots of hospitals have audit departments which will get medical records for you, which will send notes up to your office, and all you have to do is ask. Some hospitals also provide statistical analyses in their audit department, so it's always helpful to find out what's available. And my last point, but not least, is to actually, most importantly, complete the audit cycle. Lots of audits get done but never get a chance to be re-audited, and it's often less useful, especially for presenting or publishing your findings if it has not been re-audited. So that's all I have to say for today, and good luck in your clinical audits. Thank you.
Now, أول ما جيت البلد كنت متخيل إن إحنا السودانيين الوحيدين اللي ما عندنا prior knowledge about the audit wal QIPs. Like it turns out, a lot of my colleagues who graduated from other countries, they did have the same problem as well. So I asked a few of them to share their experience when they were doing their first audit.
Hello everyone, my name is Angela Ismaillo. I'm a Spanish doctor that is now working in the UK. I finished my medical school and my training in Spain, and then I came here for a fellowship. And I've been asked to tell you my experience with audits and QAPs. So the first time I've been told about them, I actually was even scared or panicking because I really didn't know what they meant. Actually, I remember I was thinking that they were like these kind of huge projects with a lot of paperwork, a lot of time consuming things, and that actually might involve even the government or the ministries. Because for me, maybe because I'm from Spain, but maybe it's also your case too, it sounds really like huge thing, but it's not like that actually. Because in fact, audits and QAPs is a thing that we all doctors do, is so attached to real work, is the way we have to improve our clinical knowledge and to do a better practice. So we all have done this before, just we call it differently. So what was really useful for me is finding what is the actual name from your own country or your own place. In my case, for example, audit is not like auditoria, which is like these false friends. It's more like a descriptive study. So you just have this bunch of patients and you analyze some data on them, and then in an audit you get the conclusions. So you think about what's going on well, what's not going that well, what you could do to improve things, and that leads you to the QIP, which is the quality improvement projects. And in these ones you do something, you have like an action on patients or on whatever you want, and you analyze if it's working or not, if it has any consequences. This is all the kind of studies we all do in medicine, because we do things and we want to know if they work or not. So the only thing you have to do, my real advice for audits and QAPs to understand them, is to think about what you've done before in your life as a doctor. What analyses have you done? Because probably you've done more than one audit, more than QAP, but you just didn't call it that, and you didn't just register to your medical council. It's just something you did because you found it interesting, or because you wanted to take it to a meeting. I don't know. I'm sure you've done it before, and I'm sure you're gonna enjoy it if you enroll here in UK to an audit and QAP. So go for it. I really encourage you to do it, and enjoy.
سلامات، أنا اسمي خالد يحيى, a junior clinical fellow في general surgery في UK. I've been asked to share my first audit experience with you, اللي هو كان على الاوديت اللي عملته في أول جوب لي لما جيت البلد. قبل ما أتكلم عن الاوديت حقي في الأول، أنا بدي أوري إنه أنا الباك جراوند بتاعي كان شنو. أنا زول خرجت من السودان، امتحنت امتحاناتي في السودان، عملت امتيازي في السودان، وكان عندي very vague idea about the audit. عارف انه هو حاجة مهمة وانه الدكاترة هنا في البلد بيعملوها وانه دايما بتسأل في الانترفيوز وفي الامتحانات، لكن الاوديت هو شنو تفاصيل شنو بيتعمل كيف ما عندي اي خلفية عن الموضوع ده. قمت لما جيت بديت اول جوب كلمت مع الكونسلتنت بتاعي قلت له يا باشا انا داير اعمل اوديت لكن ما حصل عملت اوديت قبل كده. قال لي دي اصلا اتس نوت بروبلم، يعني شرح لي قام وراني اداني موضوع وقام شرح لي التفاصيل وقال لي تعمل 1 2 3 4 5 وفعلا عملت الخطوات زي ما قال لي والاوديت كان اتعمل وبريزنتد والموضوع كانت بسيطه جدا. يعني الحاجه اللي اقولها انه النقطه الاولى اللي اعلق عليها انه انت لما تجي حته جديد بتجي البلد جديد تجي قسم جديد سبيشالتي ما اشتغلت فيها قبل كده وكده، غالبا ما حيكون عندك افكار بتاعت اوديت وغالبا حتكون معتمد على انه ناس تانيين يدوك بروجكتس او مشاريع ويقول لك مثلا ساعدني في الاوديت بتاعي وكده، ودي حاجه كويسه جدا الزول يعملها. والتعليق اللي برضه ممكن يجي داخل في الحته دي شنو انه انت ما اي زول يقول لك اي حاجه تقول لا 100 انا حامل، تلقى روحك في لحظه عندك 10 بروجكتس شغال فيها، فبي وير انه انت بتقدر تعمل شنو بتقدر تعمل شنو. يعني اتس اولويز جود انك تعمل اوديت 1 أو 2 with full cycle احسن من انك تعمل كميه وما تكون close the loops. والحاجه الثانيه انك برضه زي ما قلت لك شنو زي ما قلت لكم شنو انه اعرف انه انت الكباسيتي بتاعتك انك انت بتقدر تعمل شنو بعد كده شوف ايوه ولا لا، لانه ما دايما اي فكره بتجيك بتقول ايوه انا هعمل الفكره دي. دي الحاجه الاولى. الحاجه الثانيه بعد ما عملت الاوديت بتاعي وعملت الداتا وانالايزد وبريزنتد وبتاع وعملت الريبورت وكده، قمت قعدت مع روحي تشوف الحاصل شنو. في اللي حصل الموضوع ده موضوع دوبل، حاجه بسيطه ما حاجه معقده وما حاجه صعبه شديد. قد يكون مثلا في اوديت اصعب من اوديت تفاصيله اكثر من اوديت ثاني، لكن الفكره كاوفرول ايديا ما صعبه. الزول اللي بيكون جاي من برا ما بكون ابريشيتنج الحاجه دي. ف يعني كلمه اوديت انا حاسس انها كانت بالنسبه لي رهبتها اكبر من الحاجه اللي حصلت او من التجربه انا مرت بها. فدي حاجه كويسه انه معناتها انه الحاجه دي دوبل، بس محتاج ان الزول يعرف التفاصيل حقتها ويجي خاشي. وزي اي حاجه في البلد دي الزول لو بدا صح وماشي سال وعرف عرف الناس ممكن يعملوا شنو بيدلوه. تاني الحاجه الثانيه النقطه الاخيره كنت عايز اعلق عليها انه الاوديت دي حاجه مختلفه من الريسيرش في انه representation. يعني انت لو اخذت داتا كميه بسيطه representing الحاجه بتاعتك احسن من انك انت تعمل داتا كتير شديد وتلقى روحك انت اوفر وركت واوفر وان بالتفاصيل بالداتا كتيره والشغل كتير وكده. يعني باختصار don't overdo it, just do the right amount of data and spend the right amount of time في الموضوع ده، وما تعمل حاجات كتيره شديد انت بتقدر عليها. عموما في البلد في كلتشر ظريفه انك انت شنو انت ما توعد انك هتقدر تعمل حاجه ما تعملها. يعني تراي دايما انك انت اعرف روحك انت فاضي 200 وما فاضي 200 وتفاصيلك شنو، واختار الحاجه الصح والحاجه الابروبريت بالنسبه لك واعملها. all the best ان شاء الله.
Hello, my name is Tom. I'm one of the endocrine registrars working at Darlington Memorial Hospital, which is based in the northeast of England. It's a pleasure to talk to you today about audit and quality improvement projects. I'd like to think my perspective is slightly different than most in that I did my undergrad education at the University of Toronto in Canada, and then for medical school I ended up in Jagiellonian University, which is actually based in Krakow in Poland, and I spent 6 years there. Unfortunately, neither my undergrad nor my postgrad schools really emphasized the need for audits or quality improvement projects, and to be honest, until I actually arrived in this country I didn't really know what an audit was. So I'd like to think I was at a bit of a disadvantage because of that. Because of that, I think I probably didn't quite understand the importance of audit, especially for your career progression. So as you may or may not be aware, you need audits for your foundation portfolio, and you also get quite a lot of points when you're applying for further training. So if you're applying for core medical training or for higher specialty training such as endocrinology, you need audits and quality improvement projects to gain a certain amount of points for your shortlisting, and also you can use that as evidence of having an interest in the specialty that you're applying for. And I think that leads me on to point 2, which is if you are going to do an audit, make sure you do it in something that you are interested in. there are many types of audits that you could probably do in a day. And there's audits such as on oxygen prescribing or on prescribing of prophylactic Clexane for medical patients that theoretically you can do in a day. However, I strongly encourage that you pick a project that is something that's close to your heart and something you're interested in. It makes it so much more interesting for yourself, as well as if you're presenting it later on, you're just much more passionate about it. So I understand sometimes you just need to do an audit, but if you can, pick something that you're very much interested in. The third thing, I guess, is somewhat related to the first two. When I first came to this country, I didn't really know what audit was, and I really had to talk to my seniors about what to do and how to do it. So I do strongly urge that you talk to your seniors about what is a good audit and how to do it properly. And I was very much helped by my seniors and my registrars and my consultants in picking good quality improvement projects and good audits that were actually worthwhile. I would also strongly suggest you design a project or an audit so that you can close the loop, it's called. And this just means that you do an audit, you find areas of improvement, and you come up with a plan on how to improve these areas, and you present it to, say, your hospital, to your colleagues, and after some time you re-audit the same topic and see whether you've actually made an improvement. And this is very important in that you can demonstrate that you've actually improved something in your hospital, but it can also be used further for a presentation or a poster at a local meeting or conference. And again, not only is that good for your resume, but it's also good for applications into further training. That's about it for me, but I wish you all the best and good luck and happy auditing.
Okay, so we've had a few different experiences from different people. I hope you can relate to their experience. This is the end of the basics talk. We will do our best to prepare a second session. We are not sure when. During that, we are going to go a bit deeper into both concepts. We'll go step by step on how you can write a proposal, prepare a report, and how to prepare your presentation. What you can do from today until that time, try and think about, that's a mistake, spelling mistakes there, sorry. Think about ideas for a project. Do some brainstorming about standards for your ideas, and we'll be happy to answer all of your questions. Good luck.